Thanks, Alex, for organizing another what I think is an absolutely spectacular symposium. And so I'll get started. I've given talks in the past that have been on anterior segment OCT and on OCTA, really imaging stuff that I absolutely enjoy. This year, I thought maybe we should talk about something that we're dealing with every single day. I really wanted to show all the cool videos that we use and all that. So I thought, well, gosh, I could do that, but cataract surgery is something that's so relevant to all of us. So maybe we can talk about that. So that's what we're going to discuss today is really cataracts and glaucoma. As far as disclosures, I don't have any financial disclosures to disclose. I do have some personal disclosures. I think, thanks for all the people who've sent us patients and such. I think my outcomes are better at UCLA Doheny than they were at USC Doheny, so I'm not sure how to explain that. But I just wanted to make that disclosure for now. I don't have data, but I can present that next year's meeting. I think it's something like 100% success rate, 0% complication rate, something like that. Yeah. In any regard, so, the new sexy is MIGS, right? So, which is minimally invasive glaucoma surgery. And we're all kind of interested in MIGS, but MIGS has a real role with cataract surgery. So that's what I wanted to introduce that topic. Now, the way we treat glaucoma has changed, right? It's changed quite a bit, actually. In some cases, the way we used to do it is first medication, second medication, maybe laser, third or fourth medication, then maybe a trab or a tube somewhere in there is cyclodestruction. Now maybe we do SLT or medication first, and then often even consider, MIGS surgery that's, targeted at the Schlemm's canal. Then you can consider suprachoroidal MIGS, which is now changed since CyPass withdrawal. And then finally, consider subconjunctival MIGS, and then maybe trab or tube. You can jump straight to trabeculectomy. Of course, it depends on the patient and what pressures that you need. So there's been some change that we've seen. Now, it's called cataract surgery plus MIGS, right? So sometimes just called cataract surgery plus, because that plus can be whatever else that we want to combine. But the important thing here that I want to discuss is the actual cataract surgery, and we often forget about that portion. So that's what I want to focus on today. MIGS advantages, of course, are ab internos, bloodless, conjunctival sparing technique, minimal tissue trauma, and controlled pressure reduction that perhaps lessens surgical morbidity, and there's low risk of adverse events typically. There's absence of blebitis, leakage, chamber collapse, choroidal hemorrhage, and persistent hypotony in most cases. And you typically combine this, as I said, with cataract surgery. So that's sort of the relevance of this. So we're going to talk about cataract surgery and its role in glaucoma. Now, all of us can appreciate that cataract surgery is a very, very important and probably the primary glaucoma procedure for angle closure. And this has been shown through randomized controlled trials. And there was really not much debate about this point. If you look at the study, in patients with angle closure glaucoma where the pressure is controlled on medications, so their starting pressures are somewhere in the high teens. This is a study looking at phaco alone versus phacotrabeculectomy. What the authors found is that the phaco alone is almost as effective as phacotrabeculectomy in lowering the intraocular pressure, especially longer term. Initially, you get some increased risk of hypotony in patients with phacotrabeculectomy, so the pressures are low, but eventually sort of evens out that the differences are minimal. Yes, you do get some lowering, lesser need for medications in the phacotrabeculectomy group, but this was at least statistically non-significant. But what's significant was that the high risk of complications in the phacotrabeculectomy group, 19% versus 0% in the phaco group. So in patients who have controlled pressures, cataract surgery alone is effective. What about patients that do not have well-controlled pressure? So pressures are now uncontrolled. Pressure startings are in the 24 range. In that study, again, randomized controlled trial, phacotrabeculectomy was only marginally more effective than cataract surgery alone. So even in patients with uncontrolled pressures, they're on, 3+ meds. You can do simply phaco alone, and it can be almost as effective as phacotrabeculectomy. And certainly the same results as in the other study with almost no complications in the phaco group compared to 33% in the trabeculectomy group. More patients in the phaco-trab group lost vision, had snuff out. There were some patients in the phaco group that did need future trabeculectomy. So in this group, however, there was definitely a less need for medications in the phaco-trab group compared to the phaco group. But again, cataract surgery, very effective in these cases. And now we have the EAGLE study. So if the patients have perfect vision, 20/20, 20/15 vision, but their pressures are uncontrolled. That's what this study was, looking at clear lens extraction. This was comparing in patients with primary angle closure and primary angle closure glaucoma, randomized controlled trial looking at two groups of laser iridotomy versus cataract surgery. And in that group, cataract surgery was more effective than laser PI. But really, in this case, the point of this slide is that, again, cataract surgery achieved pressures that were starting in 28, 29, 30 down to around 16 with simply cataract surgery alone, with significantly less number of medications. So cataract surgery in patients with angle closure definitely proven and effective. So then, next question is, well, we know the utility of this. What about cataract surgery alone as a primary procedure for open angle glaucoma? So that's what we're going to talk about next. And there's been some evidence, even going back as far as 1984, circa 1984 or so, where this was a time, this was, I think this was after I was born, but perhaps this was a time when they were going from just introducing extracapsular cataract surgery. And going from intracap to extracap, they found, well, yeah, there's lower complication rate, and there's really less adverse effects on pressures and glaucoma. And patients who had higher starting pressures had a pressure reduction just with extracap surgery. So even back in in the early 80s, said, okay, well, for open angle glaucoma, you can lower pressure in patients who have just cataract surgery alone. So following up with that, Bruce Shields, suggested that not every person needs a combined surgery. They don't need a cataract and glaucoma surgery, and came up with this sort of plan as to what the plan should be. So if the patient has mild to moderate disc damage and visual field damage, maybe cataract surgery alone is an option, especially if their pressures are controlled. They don't always need a combined procedure. But if they have borderline pressures, then perhaps combined procedure or even cataract surgery alone. And if they have uncontrolled pressures, then maybe you can consider a two-stage procedure. This is back in 1986. So this is still going back more than 20 years. But not everybody agrees. Now there's controversy. This is a paper, this is the most interesting title of any paper that I've actually read. This is the title of the paper. This is a sentence. There is insufficient evidence to recommend lens extraction as a treatment for primary open-angle glaucoma, an evidence-based perspective. So these authors said, well, cataract surgery really has no role, and because there's no evidence to show that it can be effective in lowering pressure. Just because we want to believe this doesn't mean it's true. And they felt at this time, circa 2012, that there was no good evidence to show that cataract surgery should be used as a means for controlling intraocular pressure. And the question is this really true? Now, their objections to me must have been about efficacy rather than safety, right? Cataract surgery is pretty safe. And we know that from, again, lots of studies. This is a study looking at, in Sweden, they've looked at over time, over the years from 2002 to 2009 or so, looking at more than 70, 80,000 cases, and they've noticed a decline in complication rate. These three lines mean this is a group that did fewer cataract surgeries. This is the busiest cataract surgery group. All of them, the surgical complications declined over time, and it was relatively few. 1% risk of complications, 1.5% risk of complications, which is kind of published data. But they did notice, okay, patients who have glaucoma, there's a slightly greater risk for complications. So those cases are difficult. But again, cataract surgery, very, very safe and effective. Now, what about higher risk eyes? If you look at patients that have pseudoexfoliation, but they don't have marked phacodenesis or lens subluxation, even in those eyes, there was very, very good safety. Complication rates, very low between pseudoexfoliation and control groups. And really the one thing that decided it was how well the pupil was dilated. Smaller the pupil dilation, greater risk of complications in pseudoexfoliation. So even in pseudoexfoliation, you can lower pressure and it be safe. Well, what about with flax? Now that we have flax, again, very low rate of complications with cataract surgery, very strong safety profile comparing any capsular complication less than 1% between femtosecond and conventional surgery. This was when femto was initially introduced. This is done in Europe. And to follow up on that, phaco versus conventional in a randomized controlled trial, again, they had very similar and low rate of complications between the two groups. and the rate of complications was 1% or less. And what they actually noticed in this study also was that there was some mild pressure lowering in both groups. So they noticed pressure lowering between 1 and 2 points with just cataract surgery alone. So very safe, effective surgery. And then what about patients, going back to the Eagle study where the patients had clear lens extraction. These patients have more difficult surgery. They're in angle closure. Chambers are shallower. Even in that study, the rate of complications in posterior capsular rupture was quite low, as you can see here. So clearly cataract surgery can be done safely. What about if you're a resident? Residents certainly have a higher risk of complications, and it's a safe surgery even when residents operate, maybe not in the early period. In the first 12 weeks of their surgery, this is where we try to avoid doing surgery with them. This is where I send them to Dr. Giacconi, and then I can adapt them right here. So even in those cases, the surgical complication rate between staff surgeons and residents was quite similar, and this is looking at all comers, complex cases and milder cases. So if residents can do it, we can all do it. So if cataract surgery is relatively safe, then what about the efficacy? And let's talk about that. And we're going to talk about two things, for IOP reduction and for reducing the number of anti-glaucoma medications. Now, compliance is a huge issue. We all think our patients are compliant. I certainly do. Because I'm a good doctor, right? But our patients are not often compliant. They forget to take their medications. There's lots of data on this, and I don't have time to get into all those different studies. And then you have to do constant monitoring. You have to go through this whole milieu of, are you on medications? Is it affordable? Is it, do we really take the time to do all of this stuff? Likely not, because it takes a lot of time. And there's significant costs associated with medications, which is one of the barriers for compliance. Certainly, this is what this graph is showing. No matter what stage of glaucoma you have, often you're on medications, so there's a cost barrier to that, and maybe there's more cost-effective ways, including surgery. And you have to think about beyond IOP lowering effects in terms of patients improving compliance. So compliance is important. Having patients on less medications is important, and we often don't pay enough attention to that. So let's talk about now for efficacy. What about for ocular hypertension? Let's start with that. Cataract surgery is a primary glaucoma procedure. This is a randomized controlled trial from the OATS study. There was significant intraocular pressure lowering with phaco alone in the OATS study. Patients started pressures in the low to mid-20s, and pressures lowered approximately, about 4 millimeters of mercury. Not bad, Overall group, 16.5% IOP reduction with cataract surgery alone. The higher the pressure you had pre-op, the greater the pressure reduction. So you can get more than 20% pressure reduction with cataract surgery alone, in a patient with ocular hypertension. So this kind of was a randomized controlled trial that showed that. Now, clearly, you're going to be rolling your eyes and say, oh, come on, 4 points, Vic, please. When I do a trabeculectomy, I get a much bigger, profound pressure reduction. And yes, you're right. We're not comparing this to Don Budenza's study or the studies that Dr. Caprioli, Dr. Coleman, and others have shown that you can get a very profound pressure reduction with a trabeculectomy or tube. We're not comparing apples to apples. We're talking about cataract surgery alone in a different population compared to patients who need a more aggressive procedure. So keep that in mind. That's what we're talking about here. So maybe mild glaucoma, mild to moderate glaucoma. Not everybody has advanced glaucoma and needs pressures of 10. So let's talk about those patients in mild glaucoma that I just mentioned. Glaucoma suspect and mild glaucoma, now that we've covered ocular hypertension. So this is a study that was the first study actually also done at UCLA. This is by Kevin Miller, one of our colleagues, back in 1998, where modern phaco came around. So in modern phaco, what they noticed is that you get a pressure reduction about 2 to 3 millimeters, 12 to 15% lower in all eyes after cataract surgery. If the patients had glaucoma or glaucoma suspect, then you get sometimes up to 3 points pressure reduction, depends. So patients with glaucoma maybe get a little bit more profound pressure reduction than regular patients. This is back 1998 or so. And then what about in pseudoexfoliation? Bradford Shingleton has shown a lot of good studies looking at patients with pseudoexfoliation, and they found that, yes, you get a long-term pressure reduction after phaco and pseudoexfoliation eyes, either with or without glaucoma. So cataract surgery can be quite effective in these patients. And again, what they found is that the higher the preoperative pressure, the more profound the pressure reduction. Sometimes 15 points lower in these patients, up to, or 10 to 15 points lower if the pressures were 30 or so. So higher starting pressures, clearly you can get a much better effect. What about more recently? This is Shanlin, with previously at UCSF. What they did was they looked at patients, again, in glaucoma suspect and milder glaucoma. They found, yes, you can get about a 2 to 3 point pressure reduction just with cataract surgery alone. So this is, giving us data that, okay, if you have mild glaucoma, cataract surgery alone, you can lower the pressure a few points. Pretty much seems to make sense. And so why does this happen? Why does this happen? There's still not quite agreement on this because there's a number of different theories. But what has been shown that you do get an improvement of the aqueous outflow facility. This was a study done in 1997 where they found that, okay, in cataract surgery, once you do cataract surgery, you get an increased aqueous outflow. But really in patients who had a lower facility of outflow originally, in those are the patients that you improve it. Otherwise, if you generalize the results, yeah, I may improve it a little bit, but it kind of goes back to baseline after a year or so. And sometimes we see that too, that you do cataract surgery, pressure improves, and over time, you lose that effect. But in patients with glaucoma, perhaps, those are the ones you're going to make the most effect on with cataract surgery. Now, more recently, this is just getting published as ahead of print. Is I think getting published this month or so. What they've shown is modern cataract surgery, again, can improve the tonographic outflow facility. This is on top is where you get lower pressures. So this is surgery. After cataract surgery, you get intraocular pressure improvement and improve tonographic outflow facility. And in patients, other eye who didn't have surgery, the other eye, the contralateral eye didn't have surgery, IOP pretty much stays the same, and their outflow stayed the same. So it likely was related to cataract surgery that improved outflow. When you look at imaging, I certainly can't get away by doing any talks without an imaging slide, so this is that one, where you can actually see the Schlemm's canal expansion in area and diameter after cataract surgery, and it correlated well with the intraocular pressure. So pressure drop correlated well with the size that they could see on anterior segment OCT. And this is a study that looked at, well, what about the technique? Is it the phaco perhaps that's lowering the pressure? What's happening here? This is manual small incision cataract surgery versus phaco. No difference. Both surgeries led to lowering of the pressure, whether it was small incision or phaco. Okay, so in this case, 80% of eyes had pressure reduction. Mean pressure reduction was around 3.6 plus or minus 2.1. There were some eyes that didn't change pressures at all, about 7%, and 13% had pressures that increased. But both eyes had similar changes in anterior chamber and angle parameters as well. Okay, let me go back one. Okay, so oops, this thing is really sensitive, or not. What about mild to moderate glaucoma? Now, we talked about glaucoma suspect, we talked about mild glaucoma. What about mild to moderate glaucoma? What about cataract surgery as the primary glaucoma procedure in these cases? Now, in these cases, typically we're combining these patients with a MIGS surgery, right? But let's look at the data from the MIGS trials for the cataract surgery alone. So, not in patients who actually have the combined device, but the control groups only. If you look at the original study from the iStent, which is the first approved device, in the cataract surgery alone group, you get a pressure reduction of 8.5 points. It's unbelievable. I had to reread the study to make sure that was right. And so let me show you some of the data on that. So this is a primary endpoint looking at patients where, yes, the iStent did add something to the cataract surgery. More patients had pressures, less than 21 without medications, and more patients were off medications with the iStent. But let's focus really on the cataract surgery alone. So the cataract surgery alone, in half the patients, you could get pressures, starting pressures around 26, less than 21 in half the patients just with cataract surgery alone. And in almost half the patients, you could get them off medications or a 20% pressure reduction with cataract surgery alone. So pretty impressive numbers, and this is sort of a pivotal trial. It says Hydrus here, but this is actually the CyPass. Excuse me, this is the iStent group. Now let's talk about the Hydrus. Hydrus is just recently approved. The Hydrus, I haven't had any chance to implant any of those. I'm not sure Brian has either. I think there are some plans to do that. But Hydrus, again, the studies, this is a video from Ike Ahmed. Ike does everything first. So I think in Canada, you guys, Neuro, have access to all these things before we do, right? And so the Hydrus, is, again, it's a scaffold that's going to keep Schlemm's canal open. And why is this video in there? Why is it? Just to kind of wake you guys up. Yeah, I know, it's not really relevant. I know, I get it. So here's, you're going into Schlemm's canal, and then you're going to start advancing the Hydrus. And you'll see exactly where it's going to be. So you can kind of see it. And keep advancing it, keep advancing it, keep advancing it. This thing is big. get it off the injector. So this is a lumen right here, allows fluid to enter, and then there's actually areas where there are windows that allow fluid still to go through the trabecular meshwork, and it expands Schlemm's canal as well. In any regards, so looking at the trial, the Horizon trial, 2-year study, we're going to look at the group, again, that's cataract surgery alone versus the hydrous. And so pretty well matched groups. What they found in that study was that this is the in terms of 12 months and 24 months. And here we're looking at patients with 20% pressure reduction and then the mean change in pressure. So the mean change in pressure, you're going to be looking at this gray scale. That's the cataract surgery alone. Yes, the hydrous did add to that, but you're getting between a 5 and 6 point pressure reduction just from cataract surgery alone in this group. So again, these are patients with pressures in the mid-20s to start with. If you add the MIGS device, you get another 2 to 3 points in addition to the cataract surgery. But you can see that the bulk of the procedure that's helping is the cataract portion, not actually the MIGS portion. And then what about CyPass? CyPass has been obviously withdrawn from the market. We're going to talk a little bit about that a little bit later because of endothelial cell loss concerns. So we're not going to talk about the patients who had the suprachoroidal shunt. We're just going to talk only about the patients in the control group. And in the control group, here, you're looking at pressure reduction more than 20% from baseline, 12 months and 24 months, more than 50%, 60 to 66% of patients had achieved that endpoint. And again, 5 to 6 point pressure reduction in the control group with cataract surgery alone. This is again in patients with mild to moderate glaucoma. And then of course, to summarize all of this, in patients with open-angle glaucoma, pseudoexfoliation glaucoma, and angle closure glaucoma, you can have pressure reduction. This is from the American Academy of Ophthalmology publication, and the number of medications is reduced. It is more reduced in angle closure than pseudoexfoliation, and then in open-angle glaucoma. And timely cataract surgery is important, right? So perhaps, it's been advocated that maybe you should do cataract surgery before you would consider trabeculectomy. Well, why would that be the case? Why is that important? Well, it eliminates the risk of cataract formation after glaucoma surgery, which we know it happens. And then, of course, it prevents this shallowing of the anterior chamber. So, this is a very, very important point. So it may reduce the complications of trabeculectomy if the patient was perhaps pseudophakic. We know trabeculectomy leads to cataract formation. This is a study that was done in Asia where they looked at patients, and half of the patients in the study, they were looking at 5-FU in terms of trabeculectomy. More than 50% of the patients needed cataract surgery. More patients needed cataract surgery than were able to achieve success in the surgery, okay, for the trabeculectomy. So clearly, cataract formation occurs. If you look at the AGES study, Advanced Glaucoma Intervention Study, 78% increased risk of cataract development. In the SIGES study, 8 times greater risk requiring cataract surgery versus the medically treated group. And the collaborative normal tension glaucoma study, 30% of patients required cataract surgery in 5 years. So any of the glaucoma procedures that we're doing are going to induce cataracts. And so you say, well, is it harmful to do cataract surgery first? No. If you look at the study from Dr. Caprioli, Simon Law, they looked at patients and they compared 2 groups. They looked at patients who had cataract surgery first versus not, so pseudophakic versus phakic. They got equally excellent results. That's the reason I put this in here, to show that UCLA excellent results. That's not the only reason, but it's a good reason. But anyway, so you can see that whether you have the cataract or not, you can get good results. So doing cataract surgery first does not make it any more difficult to get a good outcome. So maybe we need to now think about lens-based glaucoma surgery. It's the new MIGS, phaco plus procedure. So if you have well-controlled pressures, even advanced disc and visual field damage, pressures are good. Maybe cataract surgery alone. Get a couple of points out of it, fine. If you have borderline pressures, you can still consider cataract surgery alone, or maybe now you can do combined procedure, and that's where we're going to shift to cataract plus. So we're going to go from these borderline pressures, instead of doing a phacotrabeculectomy, maybe you can consider doing cataract plus procedure, save the combined procedure for a little bit later on, which you can always go to. So I think the paradigm sort of is shifting in that, and the cataract surgery certainly is becoming a way of lowering pressure. Thank you.